this is really exciting stuff, like when we have like meetings, especially initially, like these are things that like trying to tell my wife about because I'm excited about it, and she's like, she's not in medicine, so she's like, I have no idea what you're talking about. but it's cool, right? And I think
I'm happy you're happy.
Yeah.
He seems really excited about this.
No, but like it's great.
I should smile at him. Yeah.
But it's cool but like if you anybody with any
any clinical background,
even no clinical background, to say, hey, this is what normal arrests look like. This is the percentage of patients that live, and this is what we can actually push that to. Like that's every single one life that could be different is a massive change. Right?
EMS provider out there that would hear that would then buy into it and say, if this is available to us, let's make this work.
Absolutely.
I would hate to say that anybody out there would, let's just work it like we did.
No, I think in looking at a lot of my departments, especially ones that just unfortunately have a lot of cardiac arrest patients, right? You see it when you see, patient like DOA, right? Or every time, right? And they end up dying, and it's really hard to see, and it's demoralizing, right? And you're looking for that like one or two really great saved cases that you made such a great impact on a patient that can carry you for years, right? I remember patients from back in residency that I know we made a great save, right? And I remember everything about it. And so anything that can really save a patient, that normally would not be saved, if it's a win. It's a win, right? And it's a huge win.
So you said in like a calendar year, you usually get about 100 cases?
We have 100 ECMO cases.
Okay.
ECPR cases. So there's probably, based on our like geospatial modeling of kind of all of the folks in the catchment area of Cleveland Medical Center, you have probably about the potential for like 40 to 80 cases a year, just based on pre-hospital stuff. Mm-hmm. Now it's 80, and then we have bystander CPR as part of it. Our bystander CPR rates are 40-something%. Right. Yeah. That's right around the national average. That's not a Cleveland problem.
Yeah, no,
that's a U.S.
sad,
problem. Like if you go to Scandinavia, that number is like 89%. Like it's bananas. But so you take that down to now 40 cases, and then we have our, blood gas criteria and end-tidal CO2 criteria once we get in, and that's going to drop out another half. So you're looking at potentially really 20 cases a year, and that's, that's a lot of work to do for 20 cases.
Yeah, so that was my question. Out of how many do you get paged to or alerted to do you actually succeed in becoming an accepted patient that you were?
Actually can.
So we've had, so I think currently we've had around 36 activations, all right, for which 12 have been cannulated, 1/3, and of which about, 7 out of those 12 have walked out of the hospital. All right.
That's still amazing to me. I mean, that's a chance they didn't have.
Right.
So
yeah.
I mean, all these folks, Absolutely. if you run those same numbers, like that, you'd expect one to walk out of the hospital by like so.
Of those 12,
if you model that against standard practice,
Yeah, and that's why a lot of our discussion, our thinking is how do we expand that catchment area too, right? Because then you increase those numbers of patients that could get this therapy, right? And so you were asked earlier about like future directions. In my mind, thinking of how can we expand this just out of our main campus in terms of that, and then also now with other hospitals that might be involved too, like how do we make it an actual regional thing where the entire region is really getting excellent care in any area, right? And then on the EMS side, how do we make this as once this capability is more widespread and it's not just one niche of Cleveland, is how do we make this part of our normal algorithm that we're looking at, right? When we're looking at our VFib and VTAC shockable cardiac arrest algorithm, like this should eventually, hopefully in the future, once it's more operationalized, be part of our normal algorithm that we're thinking
pop
of
right
these
out.
patients.
And unfortunately, other than going out and pushing as hard as we can about doing CPR on the layperson, there's no hyping the public out about this. Like you really.
You bring it up, right? It's the entire chain of survival.
Yeah.
Obviously, this is a ED or maybe pre-hospital, but still, it's a medical intervention. Like, if looking like better public health would lessen the burden of all of this, right? Sure. And you'd have far more cases if you had far more bystander CPR trained people and around the stigma. Thank goodness we're doing just kind of push only or compression only CPR.
Helps.
That helps a lot. And, so I think if you want to look at a comprehensive program, that still has to be part of it, right? Because they're
Absolutely.
in our protocol, how it's written, they have to have bystander CPR. That might change, because the natural history of cardiac arrest is you may start VFVT, but if nothing happens, you're going to get into PA assisted, and that's probably declared itself. But if you find someone who's still in VFVT, they probably still have a good.
They have something to work with, yeah.
Right.
Yeah.
And
Absolutely.
How important was that 5 or 10 minutes of low flow time?
Yeah.
And there's some programs that don't have bystander CPR. Minnesota, for example, was just initial, and still is, initial shockable rhythm. Right. They don't have bystander CPR being part of it. The places in Prague don't have that as part of it. They also don't have initial shockable rhythm. So there's ways you can kind of try to curate your inclusion and exclusion to get, hey, how do we get this support to the most cases versus how, we intentionally made it pretty exclusive. So how can we make sure we're going to get people that survive? And I think that's the first step, is getting that proof of concept, and then expanding your indication,
working that balance,
right?
Yeah.
Expanding the people we're doing it with.
Who's the deciding force on that, on whether or not you'll expand or not? Is that 2 people? Is that a board? Is that?
So I think right now, before it was it's the people in the ECMO leadership, which are myself, a cardiothoracic surgeon, Dr. Obama, and then our EMS colleagues, because EMS is essential
big part of that,
to this.
Yeah,
if your EMS doesn't work, this doesn't matter. All right, because we can put people on pump, but if they've been down for 75 minutes, we're not going to do it.
Right.
So it was really it was a small group of people of, hey, we're going to start with this. And now that the clinic is interested in joining, it's a great stop point to be like, hey, let's look at this.
Let's reinvestigate.
And have we been overly prescriptive in our inclusion criteria and expand it? And I think that's going to be the discussion we have over the next couple of months with our CCF colleague because we only want one protocol.
Absolutely. Yeah,
right?
We've talked about that a lot.
Because it doesn't make sense to, have like a tyranny of small differences, be like, we want to do this and that. Like, it has to be, if you have an arrest in Cleveland and you meet these criteria, you're an ECPR candidate and you're going to wherever's capable. Because that's going to be the simplest and most effective way to operationalize.
It's so exciting, though. I mean, to have them interested now, and hopefully Metro, and that's pretty exciting.
Yeah, that's a hope. That's the 1 in 5 year plan. We'll see how it goes, but you take the small wins and.
Yeah, I think that's the long-term vision, but we've been building in the right direction for sure. Right?
Yeah.
And so far the meetings we've had with the Cleveland Clinic leadership behind their program is they're fully on board to work very
that's awesome.
closely with us, and they've been very impressed in what we've built so far. And we've had a lot of good very positive discussions, which is great.
Yeah, so it'll be 3 years in October since ECPR was even possible in Northeast Ohio, and then going on year 4, if we're now getting a second system, that's
amazing.
That's far more than anyone could have thought.
Had anticipated.
Anticipated, right?
Yeah.
We weren't thinking like, if year 2 Metro isn't doing
we can
this,
get them in. Yeah, right.
Yeah, no, that was never the thought.
Yeah. So your pH and your lactates that you get, is that an arterial draw, venous? Doesn't matter. And if I walk in with a venous drawn blood, because my machine's doing all the work, all I have to do on the ride over there is push shock, push some drugs. If I walk in with a tube of blood, does that speed up your time, or does it have to be an ABG?
So the Minnesota, because they were in the cath lab, they did ABGs. Part of just in RED, we do VBGs. And obviously that's because we're not usually doing femoral access for a lot of these arrests. And obviously it's easier to get. So we were doing VBG-based ones. I would take any post-arrest VBG. Ideally, you want it at the time you're making the cannulation decision. And all of these things are not prescriptive, right? You're going to have to take the clinical context. To
sure.
A 38-year-old with bystander CPR, even if their pH is 6.99 under that 7, it's not going to be like, sorry, bud. That's a bad day for you. So usually it's going to be based on an ED draw because we want, It depends on when. If you said, hey, we just drew it 2 minutes ago, sure, because that's going to reduce the time to potential it. But like if it's like, we drew this 20 minutes ago, things may have changed. That we'd probably want a better sample.
Right.
Fair.
And I think, like Colin said too, and I've had a few of these as the ED physician, right, for these patients, and every time that I've had the CT surgeon, even if they're like questionable, like borderline, we've had really good discussion, right? And I've had a couple times where they've been like, oh, I'm going to be there in a second, let's talk about it. And they get there and we kind of go through everything and really weigh everything, really try to make like a good decision for the, can we offer this for this patient, right? And like you said, it's a little situation based. We try to make it as cut and dry as we can, right? To really just cognitive like offload that of people, but really trying to find anybody that we think this is going to benefit and be able to get that to them.
What else, have we missed anything? What else in the eCPR space needs to get out as far as messaging? Or
I think one thing that's come up just on the MS side, and we've kind of talked about this too, is what do you do with that patient that is shockable rhythm, right? You've identified them, they meet criteria, you start going, you call in everything, and then your rhythm changes, right? And you're no longer a shockable rhythm, you're in a PEA or something, right? That is a lot of gray area, I think, and that is a little bit situation dependent, because one, we've all seen those patients that are clear asystole, great, or PEA, maybe it's something perfusing, I don't know, right? Maybe that's a fine VFib, I don't know, right? And so what I've taught, what we really encourage is if they met criteria, you call it in, just continue, right? Don't overthink it, don't call back in and try to cancel, just keep going, we will sort it out, right? We'll see. If they had a brief PEA and then they're back in a shockable rhythm when they're in the ED, there's really no reason why that couldn't be a candidate,
seems
right?
completely reasonable.
If everything else fits.
And our inclusion is initial shockable rhythm.
Absolutely.
Right. And that's what Minnesota's is. That's what all these places that do it, because the natural history of rhythm disturbance following cardiac arrest ends in a systole PEA. And if they were a good candidate 20 minutes ago, if everything, and that's one of the reasons why we do the blood gas stuff, is like, it gives us an idea of the the physiologic milieu that we may be cannulating into. But if they're in PEA systole in the ED, that's not an exclusion. That's just, let's look at everything else and fantastic. Obviously, if they're still in a shockable rhythm, that portends a better outcome for them.
Sure.
Right, sure. But it's not so much to say because they're in a PEA or asystole when they get there, they're going to have a bad outcome. Those are not the same thing.
But I've gotten those questions a lot, case by, I had this case, would they have been? I've gotten that question a lot when I teach this to EMS providers, and I think that's
actually a great question.
Yeah, it is, right? And it's the whole thing is we don't want people to having to make all these very judgment calls while you're trying to do an arrest, right? It's just, hey, they meet that criteria, let's go.
Let's go. Right.
Do the things that you've been doing for years. You know what to do. Just get to the hospital earlier and call it in. That's all you have to do different.
Do you ever butt heads with a cardiologist that says, I just did an EKG on this patient and I think this is a block, we're just going to take him to cath lab? I mean, do you ever find, I don't think that you would, but...
So the difficulty we have is getting all these folks actually cathed, right? Because Ohio is a public reporting institution for cath lab outcomes.
Right.
So you, on your cardiologist and it's on your cath lab, that you're going to take a patient who just died, who's now on ECMO, and then, so you have looking at it one way, you have a 70% chance that person is not going to live. And that's going to be on your cath lab. So it comes down to cath lab volume and just, hey, are we a place that we're supporting this program? And our interventional cardiologists have been pretty great about it, because our cases have not been overwhelming. We're not having 100 of these a year. That it's really digging into those quality, but it's something that we had to physically talk about. Whereas other places and CMC is not a particularly high volume elective cath, so these numbers could actually, these cases could hurt their numbers that are looked at. So right now the understanding is, and we know this from the cath, obviously if they had a pre-hospital STEMI or post-STEMI, they should go right on eCPR. If they don't, we can probably wait, because we're going to know in a couple days which way it's going.
Sure.
Right, and and we know that from the, the cath literature after cardiac arrest, and that's reasonable. And once again, these are all conversations too that we can have. And that's been the nice thing about having a multidisciplinary process is I know who the interventional cardiologists are. I know who the CT surgeons are. I can call them up and be like, hey, this is the case. All right, what do you think? What are your worries? What are your concerns? And then they can be like, how about we wait 24 hours? Or no, that's reasonable. Like, he went down, he's 45, his dad died of an MI at 45. We should take a look.
Yeah, gotcha.
Yeah, I think, like Colin said, I think the most important thing of when we were building is we built with all of these people together, right? Everyone was part of this process. Like, I remember even the most initial meetings, right? We had interventional cardiologists, CT surgeons, right? Colin, we had other ED leadership, we had me on the EMS side, right? And all of us had input into this criteria of the process of where do we do it, how do we do it, everything, right? And so we all kind of built it with everyone's input, everyone's concerns for their specific focus, everything, right? And I think that really helped, everybody be on the same page and really be on board for this.
And somebody, not necessarily ECPR, this is just my curiosity. So if there's somebody put on ECMO, causation, I think, kind of irrelevant to my question, but they're on ECMO up in the unit. Do you just trend blood gases to determine essentially how to titrate this, or how does that functionally work? How do they decide? Well, I guess that kind of enters into my next question. Is I assume you can titrate the percentage of oxygen. I imagine, and I know you can control the flow. So does that just show up on a standard ABG? Do you just tune it, be like, all right, draw me another one? Okay, I had a couple of turns here.
So just ask a clarifying question. Is really the question, like, how do we know that they're having cardiac recovery on someone who's on ECMO?
Yeah, let's say, let's go outside of the ECPR realm and just somebody on ECMO.
So yeah, so
who's who has some systemic hypoxia for whatever reason, right? And you guys have them on ECMO.
So VA and VV, weaning and manipulation, are going to be different.
Yeah.
All right. So VA, we're going to look at a couple things, right? So we have retrograde flow in these cases. So we're going to look at pulsatility on an A line, right? Okay. If you have good pulsatility in the face of that afterload, you probably have a good ejection. All right. And we're also going to look at, resolution of multi-organ system failure, as well as are we seeing any complications of the ECMO itself? Limb ischemia being one, acute kidney injury being another, kind of all these things, right? As people get better, you'll see their pulsatility on their A lines improve, their pulse pressure improves, and then we'll do some fairly specific weaning trials with echocardiography. Where we will turn down the flows. Most people we're going to try to achieve flows of 4 liters-ish, depending upon your size. Okay. But 4 liters is probably going to support most people. Basically, under ultrasound, under echo, we turn down the flow to like 3, 2, 1 liter. And then we're going to look, what are they doing hemodynamically? If we have a PA cath, we have a lot of information. If not, we may just look at how's their map?
Yeah.
Are we, are we having to go up on the vasopressors and vasoactives in the background? And then what does physically their heart look like? Ideally, if it's just left-sided failure, this should be improving because you're taking away afterload with reducing that aftergrade flow, and you can see that improve. If it's if it's biventricular, the RV actually gets loaded. You offload the RV on ECMO by taking away all that venous return.
Sure, of course.
So we have to look at both of those and kind of see how they. And there's various echocardiographic things that we look at, plus how the patient's doing. And then, obviously, protoplasm and pathology, right? Have they been revascularized if they had an occlusion MI? That's probably going to be important, right? Whereas if we haven't fixed that, why would they improve?
Right.
Did you fix the underlying problem to begin with?
Renal output probably is huge too.
Right. We're going to see how their kidneys do and all of these things. And then once most of these ECPR ones, their hearts are reperfused, and they've been revascularized. They have their stent, and they're like, yes,
we're happy.
The heart's banging. That's not the organ we really worry about. We worry about the brain.
Yeah, of course.
So the anoxic brain injury can be devastating, even with with the lowest low flow time and everything else that we can do. All right. VV ECMO, basically, there's 2 things that you can manipulate. One's the FiO2 going into that membrane oxygenator. The other is the sweep gas. Thing about that is the minute ventilation. That's the amount of liters of flow going through that. Yeah. And so as you come down on FiO2 and come down on sweep gas, basically you're lessening the mechanical support you're getting through the membrane oxygenator. And once they're on like 21% and like less than a liter of sweep, and your ventilator settings are also reasonable, they're probably okay to come off. Yeah.
Huh. That's fantastic.
Yeah.
I have a question with that too. For you talk about a lot of these physiologic parameters, and you mentioned at the 72-hour mark is often when you're doing your neuroprognostication. And for me, being in EMS and ED, that's usually the last time that I'm seeing these patients, right? And that's what I've always been taught too. Even in regular cardiac arrest, usually that's 72-hour ROSC. At that 72-hour, even these patients on ECMO, do you usually know by then, like you're for full neuroprognostication, or at least enough? Or is there times where you're not sure even at that 72 hours, right? And you are not sure if they're going to have a neuro outcome recovery, or you're not sure if they're totally brain dead or anything like that?
Yeah, so I think 72 hours is when we can actually say, hey, you might be brain dead. That's what I tell families of patients is, hey, for the next couple days, we're not going to know if your loved one's going to wake up or not. We can't know.
Yeah.
All right. There are things that may signal that things are going well. Obviously, if they start moving and following commands earlier than that,
right, sure.
Awesome. Right? Obviously, if they're in, we do a bunch of other stuff when it comes to EEG and some other things. At 72 hours, we can then actually do kind of the formal neuroprognostication. Most of these folks will be off of sedation until they prove they need to be on sedation,
right,
which is a good sign, right? And then at 72 hours, we can do our neuro exam to look at their cranial nerves, to do some of these like brain death testing. And if they're brain dead at 72 hours, then they're brain dead. They're dead. If they're obviously, most of our ECPR folks have woken up in that period, so it's a moot point.
Right.
And then there's going to be a lot of folks that aren't brain dead, but aren't what they were before they got cannulated, and those people get more time. And we have discussions with the family of, this comes into, anyone who's ever done neuroprognostication. It's hard to know, right? Based on protoplasm, based on all those things. But what we do know from, post-cardiac arrest is the longer you wait, the more people will wake up and be normal. And it's more we just have to be patient. But we use that 72 hours for, hey, this is as early as we can declare you brain dead. And then if not, your brain's going to boot up, and who knows what you'll get to. Obviously, younger, like lower flow times, all these things are going to be predictive of better outcomes, but we'll see. But I mean, you've probably seen people that and there have been case reports, and we've seen it where they wake up on they get flow, and 20 minutes later, they're looking around.
Yeah.
Right? You've had people who've done with compressions,
So we just had... I don't know, I forget if you were on during our regional protocol meeting. Well, we were talking about patients who might need sedation during CPR because they're awaking during CPR, right? And
those patients should go on ECMO. Right? If they are awake with CPR, you just get them. It doesn't matter if it's an hour, because you'll be like, he was like that time. Every time you stop compressions, that's when the arrest started again. It's like it's been about 35 seconds. So
that's awesome. That's absolutely awesome. All right. Anything else, guys? This has been a fantastic discussion. So.
Absolutely.
Hey, I appreciate both of you coming on. We have our
awesome
man
no cash value challenge coins for both of you.
It's a good weight.
It's
a little bit of weight to it. Those were the lead ones.
Thank you very much.
We minted them in our garage.
Thank you.
I appreciate both you guys coming on. This has been absolutely fantastic, and actually, I'm looking forward to the live. So I think there'll be a lot of good conversation around.
Yeah,
this,
thanks so much for having us.
Yeah,
you can tell we've started and been pushing this program for several years.
Yeah.
We're both very passionate about it, I think, and really see the benefits.
And this starts in the pre-hospital setting.
Yeah.
Right. This is contingent on EMS care and EMS buying into this and, moving people to capable centers. And so without the EMS expertise in the operations, this just doesn't happen, and it can't happen. So thank you folks for making this possible, because without EMS, it just won't.
And we are international viewers, so... We have international viewers, I should say. So, your message will reach a lot of people, hopefully.
Absolutely.
So.
Also, this is coming. This
absolutely.
was something that was like, hey, a little cowboyish. Now, New York is developing a municipal protocol.
Yep.
Boston has one. LA has one. Minneapolis has had one. Now Cleveland. This is coming. So as much as this seems far out, it's also prognostication will become the standard of care for these patients
in
geographic areas where it's feasible.
It's the future of cardiac arrest. It really is. Just like how thrombectomy was for large vessel strokes, right? That is now standard of care for large vessel strokes, right? And that came pretty quickly, within a couple decades.
Yeah, absolutely.
And similar in my mind for ECPR.
Awesome.
Thank you guys.
Thank you all, and we'll catch you all next time.